Okay, good afternoon. I'm Al Tallia, and I'm going to be moderating this afternoon's first event, which is a group of superb panelists that really will have a lot to offer to all of you in terms of how this gets done. So, you know, we're here basically to start a dialogue between researchers and community stakeholders, how to craft a New Jersey-based, health-focused research agenda that really addresses some of the important health concerns, specifically disparities of our New Jersey communities and the research priorities of funders. So before we get started, I just wanted to say, could we just thank our IT people as well as our servers who brought us this wonderful lunch. They've done a great job. We really appreciate the hard work that's gone into preparing this, and also for the New Jersey Act staff that has really done a formidable job in terms of putting it together. So thank you. So I'm going to ask each of our, and I should also say that we have well over 70 viewers on the website too, which is an extraordinary number. Including my mom, and basically she'll provide feedback later. But before we get started, I'd like to have each of our panelists introduce themselves briefly. Miriam.
Good afternoon. So my name is Miriam Mason. I'm Director for Community Health at Robert Wood Johnson University Hospital, New Brunswick. Our role there is to improve access to preventive primary care, education, health services to the vulnerable populations that we serve. I've been at the hospital for 28 years. Our work is around community health education, chronic disease management, health promotion initiatives at the community level, and early detection and screening programs. I'm also responsible for the RWJ Barnabas Social Impact and Community Investment Initiative at the hospital, which in New Brunswick is around healthy homes. And I also are responsible for doing every 3 years a community health improvement plan that is based on the community health needs assessment that we put together.
Great, thank you, Madam.
Good afternoon. I'm Anita Kinney. I'm a professor in the Department of Biostatistics and Epidemiology in the School of Public Health, and I'm launching a new center for cancer health equity, and I'm the Associate Director for Cancer Health Equity and Community Engagement. So my role here is to really build health equity research throughout the state of New Jersey and beyond in our underserved, diverse communities. And that's a special focus of our research. It takes an army, as Melissa had mentioned, and so we have a large growing team of community outreach cancer specialists, as well as faculty doing research in multiple areas of cancer.
Excellent.
Good afternoon, everyone. My name is Dianne Hill. I am the Assistant Chancellor for University Community Partnerships at Rutgers University-Newark. I've been at Rutgers University for over 30 years. And my work in the area of Newark has been building partnerships beginning from, and I always say from the womb to the tomb. I work from the prenatal to working with the seniors. Our work is about really building bridges to the community. Our work is really how do you do that, and I'll talk a little bit more about it. But basically my research and work has been how do you link this community engagement work and you turn it into what is the term that everyone is using now with your anchor work? And are they the same? And are they connected? And how are they connected? And how do you work with the community? You know, when you're talking about health issues, how are you addressing those strategically as researchers? And how are you building these partnerships with the community? So hopefully you'll hear more about that, but that's basically my work. It has come from the concept of, many of you know, the Educational Opportunity Fund program, where we're preparing students to play a key role and transitioning them back into their communities. So my work is primarily, while it's with researchers and faculty, it's also involves students. Thank you.
Hi, good morning, good afternoon, everyone. Sorry. My name is Amanda Medina Forster. I'm with the Department of Health. I'm the Executive Director for the Office of Minority and Multicultural Health. I'm fairly new to the office, 1 year, but I've been doing a lot of grassroots education and community outreach and research for a very long time, started in Texas and now in New Jersey. But the office is very focused on health equity lens across all the divisions. So we have many divisions from HIV, maternal mortality, infant mortality, we have so many other infectious and chronic diseases that we're working on. And my office is charged to look at a health equity lens across every policy, system, and environmental change. And so we are a small office, but we are growing pretty rapidly. And we're working with many of our stakeholders. And again, just like everyone's saying, it takes an army. So we're having many of our partnerships, and we're giving a lot of money to grantees that are working with us to do health equity work, and I'll talk a little bit more about that later.
Hi, I'm Mary O Dowd, and I work here at Rutgers within RBHS doing population health and health system integration work. Prior to joining Rutgers, I was the Commissioner of Health at the State Health Department here in New Jersey, and I served in several roles there under both Governor Christie and Governor Corzine. Before that, I worked in hospital finance at NYU Medical Center and with state policy and focused on health and education policy both at the New Jersey Hospital Association and with the state legislature. Much of my work now is doing a variety of different multidisciplinary projects and other assignments as given to me, including, for example, serving on the University Hospital Board of Directors in President Barchi's statutory seat, where I get to also serve on the Community Advisory Board with my colleague Diane. As well as doing a lot of work to try to integrate some of the healthcare and public health work, which, if happily married, I believe is population health, to engage in a way that they can cooperatively leverage their various strategic assets to make an impact on improving health here in New Jersey. I am a Jersey girl through and through. I am a Douglas College graduate, and I have lived and worked in and around New Jersey my whole life.
Hi, my name is Dorothy Reed, and I'm president and co-founder of an organization called Sister to Sister. We are a breast cancer organization serving underserved and minority women. I started this organization, we started the organization 19 years ago, simply because there was 4 women, African-American women. We've seen the statistics that were shown earlier about African-American women dying so much more than other ethnic groups that we wanted to do something about it. We were gonna just shed light on it and solve the problem in a year, but it's been 19 years. We've seen the gap close up a little bit, but still there's a widening when you get to disparities. Our organization was formed mainly to hold support group meetings to find out why women were dying. But after holding meetings, we found out there were other reasons women weren't continuing to get their services. If you're head of household or your parents are out of state, you have to work, you don't get paid if you don't work, there's other factors that come into play. And women say, well, maybe I can skip chemo. I think it has something to do with education, because they don't realize you can't just skip chemo and make it up 2 months later. They put you on a certain platform, and you got to keep up with that platform. Women that are underserved and minority women, a lot of time without the education, don't understand that. So a lot of time they would miss treatments, and that's why I think part of the reason, that's not all the reason, but part of it is why the statistic rates for women of color is so much worse than other organizations. But our organization do 3 things now. We do education, have support group meetings once a month. We do bring awareness to the community. We have a 5K walk coming up to get the community out, see all that pink, and realize, hey, something's going on with breast cancer. And then we do support. The money we raise, we give back to women that's going through treatment to encourage them. Sometimes women just need to be encouraged, that somebody send them a card, somebody say, well, let me see if we can pay you your PSE&G bill if you miss a day of work. Let us see if we can pick up your child care bill if you miss a day of work, and continue with your treatment. So we're there in their corner, not only for a day or a month. A lot of times, like myself, it took me 11 months to get through my treatment. And that's how long a lot of times it takes most women for treatment. So it's not just a daily 1 or 2 week treatment that you're in. Sometimes it takes months, and it can really diminish your financial position in your home, especially if you're head of household. So that's what our organization is all about. We're going to be 20 years old this January.
Hi, good afternoon. My name is Karen Lonzo. I'm an associate professor in the School of Nursing, and I'm director of the Center for Community Health Partnerships in the School of Nursing. Like most nurse researchers, I had a previous clinical life as a nurse and then as an advanced practice nurse, and most of that was in community health nursing, and that was all before I went into academia. Right now, I've been at Rutgers since 2002, and using community-based participatory methods, I study health promotion behaviors, particularly physical activity and healthy nutrition among immigrant Hispanic women and their families, and most of that research is done right here in New Brunswick. Many of my studies have involved the use of community health workers or promotoras de salud to facilitate health promoting interventions. And I'm really glad to be here today. We were talking at lunch about feeling this sense of kindred spirits in the room, you know. Not everybody is into community engagement, not everybody is into community-based participatory research, but it's just nice to feel the buzz, you know, of people who are like-minded.
Thank you all for being here. It's a really great panel. And so what I have is a series of about 4 or 5 questions that I think will get our juices going, broadly covering a lot of area in terms of researchers working with communities. And then I'd invite 1 or 2 questions maybe per each section from all of you for our panelists. So I'll start. The first question is really, how do issues of health equity and dissemination and implementation impact your work broadly? So, and I'm going to call on Anita and Amanda to specifically give your input on that.
So that's a big question. So I'll focus on the research and equity issue surrounding precision oncology. Most of my research integrates genetics, and my major thrust is to find ways that ensure that underserved populations where there are disparities get the care that's recommended. So I started out as a nurse and a nurse practitioner. I've worked in many underserved areas, started a STD clinic, moonlighting when I was in Houston in Martin Luther King Community Health Center. So very engaged with the population. Like Mary, I'm a Jersey girl, but I've lived outside of the state for 38 years and just moved back last year. I did a lot of clinical work at University Hospital, and to my understanding, the problems really are the same as they were back in the late 70s, early 80s, unfortunately. So I did a postdoctoral fellowship at the University of North Carolina at Chapel Hill, and many of you have heard about BRCA1 and 2 genes for hereditary cancer. Those genes were actually cloned and became clinically available in the mid-90s. Today, less than 20% of women with breast and ovarian cancer have received guideline concordant care, genetic counseling, and risk assessment. There are systematic biases in the health system, particularly with African Americans and Spanish-speaking women and men related to hereditary colon and breast cancer. So I, as a postdoc, I did focus groups. So I'm an epidemiologist, and so there's most epidemiologists really focus on quantitative methods. And I realized that if I was going to help ensure equity in genetics with the African American population, especially in the Deep South, that I needed to know what the issues were with the population. So some of my colleagues thought, wow, that's, soft stuff, going to talk to community members and do focus groups and learn from them rather than telling the community what we think was needed. So that was a great entree into disparities research, and after my postdoc, I ended up in as a faculty member, and my first research study involved developing a culturally tailored genetic counseling and testing intervention for African Americans who, through genetic epidemiologic research, were found to have BRCA mutations. When molecular epidemiologists did the initial research, those test results were not clinically available. They were done in a research lab. So years later, BRCA1 and 2 testing became clinically available. So I had been in Utah at the time, but I had a large subcontractor at Louisiana State University, and this Kindred is a large family related by blood. Hundreds of people, some of the branches of the family don't know each other, so it was a pretty large family, based in a town in Louisiana, which I found out 2 years into the study, still had segregated proms. There were lots of issues with access. There were lots of issues with cancer fatalism, fear. Most of the Kindred members had family members die of breast and ovarian cancer and prostate cancer. When they heard cancer, they thought it was immediately a death sentence. So they were afraid to find out they had cancer, but I had to go in and let them know that there was a gene in their family, and we were testing an intervention. The genetic counselors that we were using to implement the genetic counseling really didn't know the population very well. So again, I engaged with the community, the target population, African Americans. In Utah, actually, many of them were from the South, and I partnered with Franz Davis, who was a pastor at a Baptist church and was well connected with the community throughout the states, and he was from the South. So we targeted individuals to come to focus groups, and the genetic counselor presented the genetic counseling module according to the way she thought it should be done. And so I knew she was going to make some mistakes. I told her, but I didn't say, I told you so. So earlier, I think Melissa talked about architecture. So, what works for the worried, white, wealthy well doesn't work with an underserved population. And so there were pictures that were used that were not well received. So we actually hired an African American artist and worked with that artist and the community to develop something meaningful. The focus group participants clearly noted that when they saw pictures of white women, they thought only white women were affected. So those little things are really important. Then we finally developed the intervention. It was an iterative process, and the intervention was actually pretty successful. We offered the genetic counseling and testing, and we didn't see increases in psychological distress, which at the time people were worried about when they were informed that they had a gene mutation and were at very high risk for cancer. The issue really that hadn't been addressed, and in our study was really important, was access to care. So you tell people that they're going to have either at a high risk for cancer and there are preventive options, but they don't have access to those options. So knowing the community in the research was really important, and being able to navigate patients to the care that they deserved. Also within this process, it's important to educate the providers. Jeff mentioned the kind of multiple layers. The providers often there are issues with racism, and they need to be trained, and systematic biases, again, in the healthcare system at the organizational level. So we've learned over the years, I've been in this business in genetic testing and counseling for many years, and all of those layers are critical. And in my research and implementation research, we want to reach the populations that really need help. And what works in one population, you mentioned adaptability and acceptability. I think that's the first step in increasing awareness. Without awareness, people don't know what they need, and it's to study ways to do that. I'm now moving back into a field which, when I was an active nurse practitioner in immune oncology, there are also biases in treatment. Somebody mentioned, I think it was Dorothy, there's a lack of a representation in clinical trials, and I'm focusing on an African-American population with non-small cell lung cancer, where there's clinically approved immune therapy that shows a lot of promise. African Americans are less likely to get immune therapy and are less likely to be aware of immune therapy, less likely to be offered immune therapy. We need to do something about it. Less than 5%, usually less than 1% of the trials in immune therapy in cancer patients focus on white people. That can't be translated to other populations. So we're developing an intervention with Dorothy and others in the community that's culturally tailored. We hope we get funded. The grant's going out in about 2 weeks, so stay tuned. I have lots of other stories, but those are tales from the streets.
Thank you, Anita. It's great to have you back in New Jersey.
Thank you.
Amanda, does it ever impact your work at the Department of Health?
Sure. So, and I just want to thank everybody for talking about health equity and having this conversation, a very, very open, honest conversation and transparent conversation that research needs to have health equity lens, and everything we do has a health equity lens, just like what Dr. Simon mentioned. So thank you, everyone, and Shauna for putting this together. So I'm going to kind of break up your question into 3 parts. So my issues of health equity, dissemination, and implementation. So I sleep and eat and drink health equity every day, right? So my office that's what we look at. I'm under the Population Health Division, and we look at statistics every day on what the issues are in New Jersey, the health disparities of HIV. 5 times more black men are getting HIV transmissions than white men in New Jersey. Black women are dying 5 times more here in New Jersey after giving birth than white women. And these are women that are healthy. So if you remove all types of morbidities, all types of socioeconomic factors, they are still dying at 5 times more rates. What is happening to New Jersey? The lead epidemic is just horrible here, what's happening in certain areas in Newark, in Camden, in Trenton. And then we're seeing the opioid epidemic that is killing many, many white men between the ages of 18 and 55 in South Jersey, Salem, Camden. These are the major issues that we're looking at, DOH, and I'm so sitting next to Mary, who is my hero. You know, I think she's like done so much battling and won so many wars, and then we continue to do that at DOH. So that's my first issue, is the data. The problem is we have older data that we would like. We would love to have rapid cycle data from the EMRs, looking at patient information, just to see what we're doing. We're looking at data from 2017 on maternal mortality. That's not right. That is not what New Jersey residents need. So this is something that we'll be looking with NJHA. So that's one of my biggest issues, is the data. The second is we need more qualitative data. We need community members to give us their voices. Let them be heard. Tell us what's really happening in their communities. You know, and DOH is very good at doing this. You know, we are reaching out to our community stakeholders, having listening sessions with LGTB. Instead of taking steps back, we don't have time to do that. I mean, we have residents dying left and right, being affected by so many things that we have no control over, and we need to act quickly. And this is where I think science comes in, to have those researchers ready with us from the get-go, to find out what is implementation doing. Are we doing our best? What areas are we not doing well in? The dissemination now goes back to community engagement. Is that an improvement? But I think we're moving in the right direction. I think with Governor Murphy and doing an interagency policy, health and all policies, I think we're moving in that direction. We're working closely with the Department of Labor, the Department of Agriculture, the Department of Transportation, to make sure social determinants of health are being looked at. There's a lot of work that needs to be done, but at least we're having conversations, and we're having real conversations that this is not working and we need to change. So that's basically for research. We have data, we have community stakeholders, we have people that we would love to have some researchers come in and take a different look.
And it's great to hear you talk about a multi-method approach too in terms of the data. Well, great. Are there any questions on this topic from the audience? We can probably accommodate two at this point. So, is there one? Oh, okay. My visual acuity is not what it should be, so if, you know, send up a flare or something like that. Yes.
Passing out the microphone.
What happened?
I'm passing out the microphone.
Oh, okay. So somebody swallowed it. Okay.
Little bit of a difficulty with personally is attempting to do what it is that I think you guys have done in your career, which is this integration. One thing that's more of a 10-year plan, and some of the healthcare equity may be the 5-year plan, especially from someone that's coming from inside the hospital, taking care of the patients on the front line, where health equity may have failed, and now we're talking about healthcare equity. And healthcare equity is sort of the back end of this failure. So as a trauma surgeon, as a tertiary preventer, if you will, not a primary preventer, although I'm trying to understand more and more, and that more on the front lines of what's reached us because we have failed in the community. And that integration has been very difficult for me to be able to pull different disciplines together, pull different professionals together, pull different types of researchers together to have this conversation as a frontline provider in the ways that we participate with you to understand where the failures are taking place so that this large amount of population that's making it to the health may be a diagnosis of the problem after it's occurred.
Who would like to take that?
Anyone want to take
Karen?
that?
Maybe just a comment, given the trauma center or trauma care background that you have, is that there has been some great progress in prevention of trauma. So learning from those experiences might inform your current work. So for example, car seats and bike helmets and partnership with public safety and police have been dynamic changes. When I was a kid, and that's meaningful in terms of what you're seeing. So I think you can go back and look at those successes in your particular area, but I also think there's current work going on right now, in particular violence in the communities. The new Center for Gun Violence here at Rutgers, domestic violence, and how you can be part of that is then going from the patient, making those connections with the community environment and context that they go home to, and seeing that as part of your job will start that co-learning experience. So I think that might be a way to approach your work.
Being a trauma surgeon. So when your stories go to Capitol Hill, and Dr. Joseph Sakrin, S-A-K-R-I-N, he's my colleague, and we just spent a whole half year on a program together, goes to Capitol Hill and testifies in Congress, they listen. And he's doing a whole lot of work. He's a trauma surgeon at Hopkins, and he's doing a whole lot of work in gun safety and making sure that everybody who touches the ED, the emergency department, and trauma in general, if they're stored and all these other things. So trauma surgeons have a huge role to play and lots of opportunity. Another example you can look to is Trinity Health System on the south side of Chicago. The trauma team, including the nurses and all the team and the surgeons, are working together to help tours of duty for many patients who had gunshot wounds and other trauma. And so they keep coming back. So how do you get them to not come back?
Jeff?
Just a quick point on this gun issue. So coming from a state where there are more guns than people, Arkansas, these sort of measures about gun locks and gun safety don't do a great job there. So like in our culture, that kind of stuff just does not work well. And so trying to work with communities in this area, we're trying that now sort of through the suicide prevention angle, and we're getting huge resistance to these issues. So not every
question. All right. The only thing I would add to what's been said, there's actually a study going on right now at Robert Wood Johnson University Hospital in the medical ICU looking at social determinants that potentially would have alleviated or avoided the hospitalization and gotten people into the ICU. So, A, it's really great to see a tertiary subspecialty-oriented trauma surgeon in asking these questions, because I think this is just not a public health or primary care issue. It really cuts across the entire landscape of health and healthcare. So, did anybody else want to add?
I just want to add to that. I'm part of that study, and I think that we also need to take in consideration that all the resources that we need when people are going back in the community are not necessary there, and that we as
that. They have actually generated a very specific report with data to back it up that goes down to the county, sometimes community level, on their priorities focused specifically on disparities, looking at everything from asthma to violence, and there's 12 of them. So I think that's something that we should heed, because these are the issues that from a population level are affecting the most New Jerseyans and have disparities there. And so I think we should look to our public health leadership and follow that to some extent. But I also think there are other ways to look at this. And when I think about it, I ask the question, where are the places where New Jersey sticks out? And this is where I think our acts, NJ Acts, is an asset for us, because then we can reach out and compare ourselves to other areas, right? And some of the things that pop in my head are autism. My understanding of this, having looked at it over a period of time, is that New Jersey has very high rates of autism identified in our population. And I say that carefully because one of the architecture issues or benefits in New Jersey is that our school system is very attuned to doing screening and identifying and working to diagnose individuals. However, I don't think that exists in many other states. And when you talk with the community, in particular parents of children with autism that have come from all over the country to New Jersey, it's because of the fact that they see what we are doing here as being very strong. And one of the other benefits at looking at some of these areas where we stick out is sometimes there is a little bit more of an emphasis from our leaders and interest and funding. So for example, Rutgers has a Center for Autism Research. For example, the Department of Health puts out research dollars just for research in New Jersey on autism. So when you kind of ride this wave of where we stick out and kind of what's hot, you also sometimes get the benefit of resources and support from many other community organizations. I think there are many other areas that can apply to. We've mentioned maternal child health. That's clearly something in the focus. Cancer, breast cancer. It is Breast Cancer Awareness Month. And some of the others that I think are popping are e-cigarettes, vaping, and medicinal marijuana and THC, for example. Vector-borne disease, when we're looking at how environmental health and climate change is affecting human health. Gun violence, we've already talked about. And then I think the other lens to look at is how can we compare ourselves within New Jersey and then across the country with our partners from a geographic perspective, from an urban, suburban, rural perspective. We in New Jersey believe we have rural communities. I know that in Arkansas they would laugh at us, but I actually learned by working with my colleagues around the country that there is real frontier land. It's not just a place in Disney World, but there are areas around our country that are so rural they're called frontier lands still. And so we in New Jersey don't have that kind of rural, but there are clear and marked differences between Cumberland County and Essex County, and Hudson County and Warren County. And so I think that beyond the equity issues around gender and race and sexuality, we also need to look at geography and access and the built environment. So I would sort of create some multi-factor Venn diagram and put some of these things into it and see what comes up in the middle. And that's how I would try to set the priorities for where we focus our efforts here.
Thanks, Mary. Dorothy, how would...
Okay, I'm going to speak on the community and what I see in the community of some of our problems. I work with breast cancer, so we know that's a huge problem, but also it's prostate cancer, lung cancer. Another big issue for us is affordable housing. We always run into women that are sometimes don't have a place to stay or can't afford the places they're staying. When we go out to help women that come to us for our services while they're in treatment, a lot of times it's not asking for a free mammogram, it's asking to help pay their rent. Now, that's the main issue. Our community is really underserved, and the elderly. The elderly sometimes don't understand or cannot navigate. I'm glad to hear there's a lot of navigation for people. They can't navigate the system. So sometimes instead of trying to navigate the system, they just don't go to the doctor. It's too cumbersome, especially now when families are split between states, children aren't here, they have no help. So a lot of times they fall through the cracks with underserved. Our need is just trying to help people survive. We're here to save lives. Education and screening, I think, is a big thing that can help with workshops on prevention, letting women know or men know that there's preventive measures that they can take. Screening to make it accessible for everyone. Even information on New Jersey Seed. There's so many people in New Jersey that don't know about New Jersey Seed that need their services. So we need to, if there was a way to get better information and resources to people, and these are some of the things our organization do with women, to let them understand that, again, it comes with education, that if you're diagnosed early, that's your best chance of survival. You know, the fear factor plays a big part. Sometimes in some communities, they see a doctor in a white coat, it don't give them a comfort feeling, okay? And that's based on our history. We don't get into clinical trials. That used to be a really bad word in our community 20 years ago. I think we've gotten better, and we're a little bit used to listening to what the person is telling us. But then again, it needs not only be to the person that's going through the treatment, but also to the family. Because you can talk to the person that's sick and ill, and they'll say yes in the office. Then when they go home and the family say, don't get in that clinical trial. They done such and such to my aunt 50 years ago down in North Carolina. You know, you were better dead than alive back then. So don't get in the clinical trials. Those are the things that the community need to be educated on. Before we'll get into clinical trials, you need to clear the slate, say, okay, this is what happened then, and this is what we're doing now. I don't think the community understands that well. Another thing that's good that's coming out but problematic to us is the training for patient engagement. They talk about a lot of portals and a lot of apps that you can go to. Elderly don't understand it a lot of times, and sometimes young people don't either. So again, training and education. You're gonna have to show them how to use the tools that are coming out. Along with that, all the stresses in our community, obesity, problematic for diabetes, heart disease, lifestyle changes. To me, it all sums up to education. You know, the doctor spoke about in Chicago, all the hospitals that's in a certain area. I'm sure they have a lot of free programs, because we do. Rutgers give a lot of free programs, but you have to get the community out to attend the programs, to hear the information. And again, the advertisement needs to look like it's welcoming to some communities, or to all communities. I just honestly believe that it should not matter what your zip code is, whether you should live or die in a disease. It should be, I'm glad to see health equity. I think we need to cover everything to make it equal.
Thank you so much, Dorothy. Well said. So we know that we need to engage communities. We've heard a little bit this morning about some stories about how that's been done elsewhere. Karen, I'm going to start with you. You've had a lot of experience with community engagement. What's the secret sauce? How do you do this?
Well, I think I'm going to focus my comments, I think, to researchers, because I think that's a big piece. Many times it's the academic person that goes forth. Maybe they've got funding, maybe they have an idea for a grant, and they think they're, I need to go get a community partner. And I think what I would tell you right off the bat, and I realize that I'm probably preaching to the choir in here, because a lot of folks that are in here that are researchers do a lot of community engagement work. But as somebody told me one time, the choir needs choir practice. So, it's probably not a bad idea to bring some of these items up. For many of us, research is our primary objective when we go to a community and we have an idea about a partnership. And, I have to remind myself sometimes that big R doesn't mean research. That big R is Rutgers, and Rutgers is more than just a research-intensive university. But even though it is your primary objective, it is not likely to be the primary objective of the community people that you're working with. I know lots of women who say to me, I know I should be more physically active. I know I should eat better, but I got so many other damn things to worry about. I just can't do that. And so that's something to keep in mind. We can't force research participation on people. We can give them lots of what we think are good reasons for them to participate and partner with us, but we can't force this on people. I think that if you want to do work in the community, you need to look at this as a long-term commitment. This is not something that's a one and done. This is not like, oh, I'm going to do my dissertation and then I'm going to be out of here and I'll never do community work again. Or once I get tenured, I'll never do this again. This is a long-term commitment, and you need to think about that seriously. I think it's much better to go into a community with the idea that you go to someone who you want to create a partnership with and say something as simple as, what can I do for you? Looking at us as being a university with a lot of assets. And if we do our homework and we know what the concerns are in the community and there are things that we can do to help address those concerns, that should be our approach. And it very well may be that some of the earliest attempts you make at academic community partnerships are really based on a clinical partnership or some kind of an educational partnership, and the research grows out of that. It's a very dangerous path to just walk in and say, I've got money, let's do a study together. They're going to look at you like, so what? I mean, it looks to them, to a lot of community members, that this is another example of somebody who's capitalizing on funding to get ahead at our expense. And this is not something that we want to, we don't want to perpetuate that kind of thinking at all. I think the last thing that I would advise people that are thinking of community engaged research or CBPR is that to emphasize the idea that what we want to co-produce as academics and community working together is knowledge. And as academics, we bring scientific knowledge to the table. But in listening to the conversation that you had a few minutes ago, I realized that community people bring their own kind of knowledge. They bring contextual knowledge, they bring historical knowledge about a community. And when you talked about the gun thing, that was like a red light over my head, because guns are going to mean different things to different communities in different parts of the country. And as a researcher, we're not necessarily going to know that, but the community can tell us those things. So I think that in order to really have a successful synergy between the community and academia, we need to respect the specific type of knowledge that they can bring to the table, and that is very important.
It's an academic humility, right,
Yeah.
that we need to bring. I'm just wondering, Diane and Marianne, if you have anything to add?
Oh, yeah, definitely. Well, let me begin by why this is so dear to my heart. It's why this is so dear to my heart. It's dear to my heart because there was a little girl that grew up in this great city of Newark, New Jersey. And this little girl lived in a community that was by the railroad track. And this little girl said at age 2 or 3, they were going back and forth to this hospital, and this hospital was the city hospital. And then there was another place that existed. It was, okay, now you have to take her to the wellness center, which is like a dispensary where you go to make sure she gets an x-ray because there's something wrong with this child. And so this little girl ended up going in the hospital, and she lived in a hospital for 3 years. She lived in a hospital for 3 years because not only did she live by a railroad track, but that railroad track had an effect on her life and her environment of what she lived in. So therefore, it was no go out and play in front of your door, because if you went out and played in front of your door, you may have an asthma attack. It was no run down the street, because if you ran down the street, you had to make sure the street was safe in an environment. So this little girl grew up in an environment and came out of the hospital, but learned to respect the hospital and said, you know what, it's so important how you love the people that become your family when you don't, even though you have a family, you have a new family. And this little girl is me. I'm here now. I'm here now because someone, after 3 years, continued to say they believe that I can help you. I can help you understand so that you don't have the asthma attacks every other day and every week. And I think about that, and I've thought about that constantly throughout my life, and that was important because that was a health issue. And up until most recently, when Dr. Elna Hall said, you don't have a disease, you never had a disease, that's an environmental issue. And I said, what? You mean to tell me my granddaughter and my family, who always thought that they were treating a specific type of a disease, that we were treating an environmental piece? And he looked at me, he said, yeah. He said, that could have been prevented. And then I thought about my friend, who is a community advocate. And just 3 months ago, she buried her 13-year-old son, who I had worked with in the 2nd and 3rd grade. And she buried him because he had an asthma attack at his school. And they didn't know what to do because they had to call for permission first. And I say that to all of you, when you think about what are some of the real issues, we have not touched them yet. When I think about her now as an advocate who is saying, my child, the reason why, Dr. Hill, I think about this is I think about how you said you came through it. I said, yes, but I have Advair in my pocketbook right now. I have all kinds of medication that I carry with me. You didn't have the money to get them. Your son never carried a pump with him every day. You see, we have deeper issues that we're dealing with when we talk about how we deal with the community. But that's just one piece. But when I think about you as researchers and the work that you're doing, you have such an open door right now. The moment is now for you. When you talk about building co-relationships with the community, you're talking about working in true partnership. And that's hard for researchers when you have the money. It's very hard. But I want you to think about your community as the people who have the answer to a lot of the problems. When I think about how we build these relationships, I use these steps that I articulate to the community. And I really go to the gatekeepers. Do any of you know who the gatekeepers are? See? You have to learn our language like we have to learn yours. The gatekeepers are the people in the community that people trust no matter what. The deacons of the church, the Miss Mary who look out the window and know everybody's business. The lady when you go to a health and wellness center, the nurse who knows everyone's name. Those are key gatekeepers in the community. But we cultivate these relationships by building trust. You hear that big T word, trust. And you just don't get trust because you walk in and say, trust me. Trust is built through these gatekeepers. If Deacon Dixon says, you're okay, you're okay. If Deacon Dixon says, I don't trust him yet, we got to watch him, then you're going to be watched. If he say no, we had a problem with him the last time, you will not get in the door. And so part of this building trust, and it doesn't happen overnight, it happens from you proving yourself, just like you did as a child. Your parents said, oh, you want to go out to the dance? Let me see if you could come back at 9 o'clock first, then 10 o'clock. Well, it's the same way in the community. You have to earn that trust. And then you build that relationship so the community know that you're not there to hurt them. Then you can talk about clinical research. And one of these, one of the opportunities that we do, one of the opportunities that you have is to help our community understand about clinical research. Help them to understand the difference between the different types of research and help them to understand how they can be an active part of it. And then the other is that I look at this other piece. In order to get these partnerships, you have to cultivate meaningful, sustainable relationship partnerships. You see, everybody want to come in when they have a little money and put on a cape, that Superman cape. I always talk about this Superman syndrome. You put your cape on, you run in the community, oh, you did a little good, you got your data, and now you're gone. You have not shared that data with the community. You have not told them what has changed about the community, and you have not given them their own voice. So when we talk about words like, and this is what I say to the community, let's learn the language. We're base building. They say, what? We're base building. That means that all of us going to be at the baseline, on the table, at the table together. And then you know what? It's transdisciplinary. What? That means everybody is an expert, including you, at the table. So we're going to start right there at the beginning of it so we can leverage the resources that we have. We can integrate our expertise. And universities sometimes need to take a step back, and this is what I do a lot of, take a step back and be the convener sometime. Sometimes your role of just pulling the people together and the right people in the room together so that the researchers and the community people can be in even places and spaces. It addresses things like the social justice and issues that you're having, because all of you know this. When you talk about health, when I talk to people about health in my community, we're talking about education, we're talking about safety issues, because I can't be healthy if I can't even go out and walk around the corner. Don't tell me about walking in my community when I'm going to get shot if I go out at the wrong time. So talking about all of the issues. And I just thank you so much as a doctor in trauma. And I just want to share this last little piece. I began working with a lot of the students in the community early on. And everyone said, you're an assistant chancellor, why are you working with these high school students and why is that important? I said, because they're the ones going to take everybody's jobs. They're the ones that can help their own communities, and so you need to be partners with them now. So I had this little student that came in and said, I know I want to do something, but I'm not sure what I want to do in health. And she started out at Westside High School. Many of you know Westside High School. If you know Newark, you know it's one of the lowest performing high schools in Newark. But Ellen decided to give them some money for some washing machines and put them on their show, and they're coming up now because they feel a sense of pride. But I tell you that to tell you that this little girl who lived within walking distance of the hospital said, I know I want to do something to help, but I don't know what. So I said, okay, you're in the program with me. We do internships. I'm going to send you to the doctor's office, and you're going to get to taste what it's like. And she went into the doctor's office, and she came back 2 weeks later. She said, I don't like it. I said, why? She said, because I'm not doing anything but writing down records and greeting people. I said, well, you didn't think you was going to work on anybody, did you? She said, I don't know, but I just don't like it. It's not what I thought. I said, okay, what do you want to do? I know it's health, but I don't know what. How about, could I go to a veterinarian maybe? I sent her to the place where you rescue the dogs and the animals. She came back after 2 days, then she was like, I can't take it? I can't take the animals? I said, okay, now, we have to think about this. But the next time she came back, she came with her grandmother and her mother. I guess they said, we want to keep her in the program, but we want to know what she wants to do. So I said, listen, I'm just going to make her a TA with the students. They're doing some field trips in public health. They're going to go out to the airport and see about immigration issues and health issues. She went out there, she came back, she said, I know what I want to do. I said, and what is that? She said, I want to go into nursing. I said, you do? I said, okay, well, in order for you to get in nursing, you at Westside High School. The first thing they're going to do is say Westside High School, and they're going to say you need to go to Essex County. I said, so you're going to have to do very well. This young lady did very well, number 2 in the class, went to Rutgers nursing and graduated, and is now working in trauma at University Hospital and can walk to work. I say that to you because it changed not only her life, but just like you're changing lives. Those people, she said, are the people that say to her, I thank you for that. And when she's back, when they're back in the community and they know that someone cared about them in a different way and helped them, they continue to connect. So I tell you that to say that look at these intentional actions that you have as you're building these relationships with your community. And the other is alignment. Please, if that particular community, city, or the people that you want to do research with, if they're doing something else, you don't need to come in and change what they have to do, especially when you're working with school systems and others. If this is not a priority for them, that's not going to be a good partnership. So alignment is key. And part of that alignment has to do with how you do your anchor work and what you're now calling, what used to be outreach a few years ago, but now it's community engagement work. And so I kind of want you just to understand the terminology is changing, and we should be creating some new terminology today, right here. Because the whole concept of what you do is so different, and it's different, and I think all of my colleagues up here said it, for different communities, and in the city of Newark, it varies from ward to ward, not just within the city.
Diane, thank you so much. And Marianne, I know you would not agree with any of what Diane has said.
No, that's my buddy. She said it all. That's my buddy.
I just want to add a couple of things to that. I think that, you know, building relationship takes time. This is not an overnight thing. You know, you need to spend time in the communities that you want to do work in. And you need to understand what are those past experiences, those wounds that many of our residents have when they have interacted with the health system. And those wounds and those stories, they travel with history throughout generations of our community residents. And we need to come to terms with that. And we need to look at what has worked in the past with community engagement and what did not work, and learn from that and move forward, because we don't want to make the same mistakes that somebody else did, right? I think that when you work with communities that speak another language, just having a survey that's in Spanish, right, Teresa, is not the only thing that you're gonna need. You know, our people don't think in, sometimes, maybe sometimes, they don't think in those ways, right? So we need to make sure that we are asking the right questions in the right way, and they are actually understanding. Somebody talked earlier about that trusted messenger, you know? Sometimes I can be that trusted messenger, and sometimes I can't. Because sometimes, you know, I worked in this community for so long that people see me, oh, there goes Marianne, community health, my screening, did I get my mom? So if I help them answer the survey, everything is gonna be fine, because that's what they want me to hear, right? So those trusted messages need to be your community health promoters, people that look like them, that live in their same neighborhood, that you empower that community, and that when you're not there with the research, they're still there because you train them, they can continue to do this work, and you improve the assets of that community.
Thank you very much. You know, I'm just standing here listening, and I know what you're all saying is absolutely correct, but I suspect, maybe not in this audience, but maybe in the television audience viewing, people are saying, oh, this is too hard. Where do I begin? What's the first step? And I think in a sense you've just answered that, all three of you have just answered that you need those trusted agents, right? You don't have to do it all yourself. You've basically got to engage those trusted agents as sort of a pathway, and listen. It's more about listening than coming in and saying, this is what we're doing, right? So very good advice, all of you. Thank you.
And I just wanted,
Sure.
Oh, okay. You want to go first? Go
Yeah,
ahead.
I just wanted to say something about community outreach and engagement. We're establishing a student internship program to teach students how to work with communities. And so community outreach is really doing for, and community engagement is doing with. So we talked about partnerships, and the partnerships start at the beginning and go to the end, to dissemination of the research results, not only giving them the facts, but then where do we go from here, and working with them along the way.
I was going to.
Yes.
Oh, I'm sorry. Go ahead.
There's a question up in the front. Let me just get the microphone so our viewing audience up here can hear the question.
Hello, everyone. My name is Teresa Vivar. I'm the executive director of a Mexican organization called Lazos America Unida in New Brunswick, New Jersey. My work is basically to create these connections between organizations, institutions, research institutions, Rutgers University students, or other students in the state to collaborate with Mexican organizations, so small groups that we create during these years. And I think one of the things that I'm seeing now, and it's a great opportunity that we have again, because this conversation occurs years ago. I was like 20 years old, and I was invited to this conversation about health and what we can do with this new migrant community that was coming into New Jersey. I'm talking about more than 20 years ago. And then I'm seeing that these ideas of how we can connect each other, right? How we can create this trust, this respect, this compromise between us to help our community members. And I think I'm hearing everything right there again, and it's very important that we, after we leave this room, we have to continue asking ourselves, what I'm doing good, what I'm doing wrong, what I should change, who I have to connect with to continue building my work, and thinking about how this work is gonna affect community members. I'm really respecting them. I'm really bring them into the conversation. Years ago, a researcher from Rutgers University, Annie Velos, invited me to this meeting when many health stakeholders were present. And I was sitting there in this table, and nobody asked me my name, even the cross there. I was the only Mexican young lady there in the room, but nobody asked me my name, nobody says hi, except one person, that was Annie Velos. And then Annie Velos gave me the opportunity to speak in that room, and then they asked me all these great stakeholders, people in power to change things in health in New Jersey. And they asked me, we don't know what we're doing wrong, or we don't know how to connect with people. And then I told them, well, the first thing, say hi. I'm that number right there, you know, so tell me hi at least. So this is the things that we gotta change, and I hear it that everybody is important, that every person has something to give, to share with each other. And then Dr. Annie Velos taking me to different classes. That's how I learned community-based participatory action research. And the action, just that letter, or that word, I'm sorry, action, means a lot. It means, for me, that during these years, I was able to be in different meetings, to hear different thoughts, to contribute whatever I was able, and start telling that information to community members, to start the promotoras or the health promoters, work with Dr. Karen Alonso and other health stakeholders. That I think all that I ask from my community members and my experience is that find these ways to communicate among each other, right? Because you are the important people right here. You are the ones who somehow are gonna send information, data, programs to our community. And we are the recipients of, but not many times we're part of it. We're not part of the process. So my question to you is how we wanna continue building this relationship in which all these different groups, which I think Dorothy also mentioned, that we work in the same field, like, you know, working directly with the community members, how we are going to start talking, working together to ensure that all these resources, because all of us have something to give, comes out not only in research, but in programs with the actual data, because we have the way to collect it and create the programs right there, but we don't have to wait 3-4 years before this data is disseminated. We gotta stop that. It's not working anymore. And somebody mentioned as well that we have all these different programs that are not going anywhere. And the programs that exist 20 years or something like that, years ago, a continuing existence, right? Something is missing right there. And that's part of the research analysis that we gotta do. What we did wrong all these 20 years, because I'm being all this research, doing research for many years, helping many researchers at Rutgers University and other institutions, how we wanna avoid those mistakes. That's my question for you. How we wanna start, and all of them are women, and strongly women, giving all this opinion, which I'm really happy. How we wanna start getting the dots together to ensure that we don't spend money collecting data that is going nowhere and is not helping anybody.
So you raise actually a really good question. Thank you for that. I think one of the, if I can paraphrase, and hopefully I'm capturing what you're saying, but one of the questions for researchers is how do we engage in communication and be able to basically translate back to the community what their questions are, their needs, the purpose of the studies, is it a value? Basically, does it answer the value question for the community? And I think that's an important question for everybody that's engaging communities in research. Would you all agree, or just?
I would totally agree, but I think that it's something else. You begin on the front end. So many of us begin that we've already put the ideas down on paper. We've already written a proposal, and then now we're going to look for a partner. You know, I say try something different. Dare to be different. And to be different, you start with getting the ideas first and bringing the partners in on the onset of whatever you're developing. That's all, you know, that builds trust right there because you're listening and having my input at the very beginning. And one of the things that that we just started doing, and this was from our community advisory board, and I know many of you started, I think I heard a few weeks ago, many of you started building these community advisory boards, and I love hearing about them, because when I think about community advisory boards, I just had to build one with telehealth, and the telehealth, it was so interesting because they're going to study HIV. And I said, okay, this is great. I love working with College of Nursing, School of Public Affairs, Business School. Look at who is around the table. But then I thought about it. I said, oh, you want a board? So they said, yes. How about someone from the CEO from Broadway House? I said, okay, they deal with it. How about the CEO from La Casa de Don Pedro? He's been in the community. Sounds good. I waited. I said, well, do you have any people that's actually on the grounds dealing with this? And they said, what do you mean? I said, we have to find some residents, people that are living it every day as part of the board. You see, that's different. That's a different level of respect. But that's also new for even those CEOs and others to have them on equal playing fields with them. So one of the things as a result of that we did was we developed what is a course that will be launched next semester. Thank you, Amanda, for helping us to think about it, because you helped us a lot with this one. It's called, the word research gets all muddied up sometime in the community. You know, sometime if you say studies, they like to study, oh, you studying. Okay, so how you studying? Because research has a lot of different meanings to community. So we started, this is our new course that we're going to have. And we're not going to teach it, not me. It's going to be the advocates in the community. It's called Understanding Research and How It Affects Your Community. So partnering with communities to help to uncover ways to improve health outcomes. We will provide seminars on research techniques, benefits, and share the research outcomes. So now it's putting the work and the understanding in the hands of the community, not just you. Your job is to help them to get that information. Their job is to understand it and feed it back out to the community. Wouldn't that be, isn't that wonderful if everyone wrote that into their research grants?
Yeah, Diane, that's an extremely good point. And one of the things, maybe the translation to the research community, one of the things I would point out is, you've all heard maybe of practice-based research networks, PBRNs. The reality is, when those started up, it was pretty much unidirectional in the sense of people coming in saying, we want to use your practice for research, that kind of a thing. But at this point now, it's bidirectional, and some of the best ideas for research actually grow out of that community of practices. So it really, it's not, some people would see it as a burden. To me, it really is a way of facilitating discovery, ideas, right, that really we haven't tapped to the degree that we could. I want to thank all of our panelists. They've done an extremely wonderful job. Thank you. Lots of wisdom up here, so thank you. We'll take a 5-minute break, and then we'll get to the next part of the program. Thank you.